Hello, everybody, and welcome again to an episode of PT Outcast. My name is Eric Robertson, and I am your host. I'm very pleased to be joined today by Steve Milanese from Melbourne, Australia, and he's coming to us from very far away, but with lots of knowledge that's still pertinent to us. So today, the topic is going to be about standards in physical therapy and educational standards in particular. So, Steve, welcome to PT Outcast. Thanks for coming in. I know that you are talking to us from the airport, and so you're on the go. Flights get delayed, things happen, but I appreciate you being here. So, welcome and hello, good evening, I think, to you.
Yes, thanks, Eric. It's lovely. It's great to be here. Thanks for the opportunity to talk about standards.
Yeah. So can you just share to start out with, like where you're located, what your role is, what your titles are? Give everybody a little bit of background about you.
So I'm currently a professor of physio at Swinburne University in Melbourne. So it's a research role. But prior to that, up till about 3 months ago, I was the academic lead at the University of Tasmania program. So I was involved in accrediting or taking a new program through accreditation undergraduate program through the Australian accreditation process. And prior to that, I was program director of a Masters of Advanced Physio at University of South Australia. So took that program through IFOMP accreditation. So a little bit of experience in that area, but currently I'm really just involved in research at Swinburne University.
Okay, great. Thank you. And that's a new role for you. So congratulations on the new role, and I hope it settles in nicely for you.
We'll see.
You and I know each other through our work previously on the standards committee for IFOMT, and on PT Outcast here, we've mentioned IFOMT a few times. We've mentioned standards. We've talked about a couple people working to achieve member organization status, and so we also sort of referenced in our blueprint episode a top level, an excellence standard, or an excellence goal to achieve. And so, as we were going, I thought, boy, it's probably just useful to talk about what are standards, where do they come from, how are they formulated, just some big picture things about standards. And so I guess, my first question to you is, how did you get involved? How did you gain an expertise about standards?
From having program director and academic lead roles, so I both in the postgraduate and the masters, and also in the undergraduate program in Australia, so having to actually take a program through accreditation, which is a requirement obviously for all programs in Australia. Also, I've been an accreditor for about 3 or 4 programs in Asia, different universities in Toowoomba in Hong Kong and Sri Ramachandra in India, Massa in Malaysia. That's all. So have had to got thrown in the deep end as such, because it was, as an academic lead, it was my responsibility to take the programs through that process. But also then having to accredit other programs meant I had to sort of take a bigger view rather than just the Australian standards.
Yeah, I think that's similar to mine too. Is I was in a leadership role where you had to first design programs like postgraduate programs and residencies and fellowships, and as you start to do that, and your next step is to get them accredited, then suddenly to achieve that, you by necessity have to become an expert in standards, right? So you're kind of thrown into the fire a little bit.
Yeah, no, I always find I don't know if anyone's an expert in it. I've got to say, having gone through it a few times, I think you're learning all the time in it, as far as, because every program, every accreditation process seems to be slightly different, which is somewhat frustrating when you go across programs. So yeah, I hesitate on calling myself an expert on it as much as a survivor on it.
A survivor. All right, I like that. I like that framework. I might adopt that. Yeah, you're a survivor of standards. Good. So, I was thinking about this and preparing for this episode, and the first thing that I was kind of reminded about thinking about this is that standards can fall into different realms. And so today, what we're really talking about is educational standards. But that isn't the only set of standards in physical therapy or in any profession, right? There's ethical standards, which might not be clearly articulated anywhere, but are sort of like collectively owned or observed, right? There's guidelines for practice, which form a set of standards in a way, right? What's the best evidence to apply? There is standards about documentations and things like that. And then there's scope of practice. So maybe that's another question I have is, what is the difference between educational standards on one side and scope of practice on the other?
It's always a hard one because it's particularly at the moment with extension of scope of practice, particularly when you look at the advanced scope and extended scope roles, particularly in the UK and developing in Australia and in the States and Canada as well, is scope is now less well defined. And I think our process of developing our advanced practice role has gone, we haven't caught up on the standard side of it. If you like, we've gone ahead to look at our scope, increasing our scope, which is great for the profession, but I don't think we've really caught up in the standard side of it for the advanced practice at the moment.
Yeah, and I think some of the listeners here in the U.S. might not be aware of advanced scope of practice issues, because in the U.S. we really just have this one standard of you're a licensed physical therapist, right? And you can get other certifications, and you can get a fellowship, or you can do a residency. But what are you talking about with advanced scope?
Yeah, so there's much argument on the terminology, but there's two at the moment, particularly in Australia. We've sort of broken down into advanced. Well, there's really probably two levels: advanced scope and specialisation. So within Australia, we have a specialisation process, which is through our college, which is part of our Australian Physio Association, which is I think it's a 2 or 3 year program where you go through competency-based process, etc., and are able to call yourself a specialist. And specialisation is really a focus in one area. So advanced practice is more a broader scope but at a higher level. So what we're seeing in Australia following the UK model is the advanced scope practitioners, who used to be called extended scope, but now we call them advanced scope, working in ED, emergency departments, rheumatology, orthopaedics, women's health, neurology. We in Australia, not yet. We will in the next few years allow our physios to prescribe and inject, and that will probably come towards advanced scope roles in the area. So they're not, our specialisation process from our association is recognised by no one but the association. As such, it's not recognised by the government or our insurers. They're not paid more. It's purely a title, specialist, as recognised by the Australian Physio Association. So, but it's the difference between a specialisation and advanced scope. Specialisation is focusing on one area. So it might be shoulder. You might have a specialisation in one area, whereas an advanced scope is really looking at, you're able to manage a broader range of patients within an orthopaedic or emergency ED, emergency department, etc. So there's sort of really growth areas in Australia at the moment. But like I said, there currently isn't any standards for advanced scope practice or even specialisation for that matter. So we've gone ahead with the scope, but forgot about the standards.
Yeah, interesting. I think we'll wrap our conversation back to that in a little while. So everybody, put a plug in this idea of advanced scope of practice, and we'll revisit it in a minute. I think also in my mind about defining scope, you mentioned government, right? And so there's an intersection there between what is educational standards that sort of define what you should know. And then there is the scope of practice defined by the government or the state or wherever you are practicing, which is, this starts to define your scope of practice, right? It sets some boundaries. It gives you a box. And then there's, the scope of practice, which is your personal scope of practice, which is, I might not know how to do this technique. And so I ethically should not do it, even if it does fall within my professional scope of practice. So there's always different levels to these things, which is really kind of interesting to understand.
I think I see that particularly in Australia with things like E-Link, which is very popular amongst physios in Australia, but is outside actually technically our scope of practice. It's not taught in any of the universities, etc. So it's all fine until legal case comes up. If something goes wrong, then actually it is outside our scope of practice as such. So from a regulatory perspective, so it is a really grey area at the moment, I think.
Yeah, so I guess let's define and talk about educational standards. Like, where do these come from? Like, who builds educational standards? Is it just like really smart people are just sort of hatched and they wave a wand and there you have a standard? Like, how does this work?
No, I think the process fund is generally, well, I know we've been going through a redo of our Australian standards for the undergraduate program, and it's through consultation. So I know our physio board's been doing consultation in each of the states, each of the capital cities, bringing people together to sort out the terminology, the wording, and looking at updating. But it's been 6-7 years since the last update as such, so they're not being updated as regularly as they probably should be, I think, given how quickly everything's changing in terminology and focus and paradigms we work within. But yeah, so generally the way that done in Australia will be through that consultation process.
So consultation process, we I think often refer to that as like a practice analysis. Right. So you're going to people who are doing the job that you are talking about and trying to understand what is their scope of practice, right? What are the things that they're performing? And then this analysis of practice is combined then with people from universities, government agencies, other stakeholders, maybe even outside the profession, like public members. And those combine to then form this idea of like, this is what a physical therapist is. And so therefore they must know these things, right? And so I think that's an important part to consider, is that the practice of the profession itself is something that really primarily contributes to what the standards are.
It's a good way to presenting it, I reckon. That's a good summary of it. It's,
Yeah.
yeah.
So then these standards, are they, educational standards in general, do they represent a minimum or do they represent like the top of the practice?
It's a never-ending dilemma, and I don't think I think from my experience is that I don't think the authorities who are really developing it, particularly in Australia, having gone through the undergraduate accreditation process for a new program, is that I don't think they haven't made that decision. So it's very grey. So it's yeah, I think needs to be really clear at the beginning. Is it the minimum, which means there's an equal standard across, or is it gold? Because when, as an administrator, as an academic lead, I then have to I have to present my accreditation process standards, etc., to above me, and if I haven't met the questions that I haven't met it, I failed, as opposed to so everyone has a different perception of it. So that's why I think raising it's actually really important, because until we're clear on it, there's a lot of stress associated with accreditation which shouldn't be there.
Yeah, interesting. So you're talking about this experience is something happened in Australia where they're trying to debate whether standards define the top of practice like a aspirational statement,
Yep.
or are they sort of creating the benchmark which defines the minimum by which you can practice safely?
Yeah, and there's it's an interesting debate, because I've raised it our board and was told the problem with setting minimum is that's all that people will do and no go past that, and I actually dispute that, because I don't know of any physio, particularly in the academic sense, maybe I've been lucky, who thinks I'm only going to do the minimum. I just think that's not within our professional psyche. It's just you don't just do the minimum. You want to do the minimum so you know the standard, but you always aim higher. I've yet to meet an academic who doesn't.
Yeah, that's an interesting thing, right? It's a carrot or the stick kind of thing. So if you have standards that are minimum, I guess in my mind, you've said, okay, I'm going to set this at a high enough level that everyone who does this is going to be a competent physiotherapist. They're going to apply evidence. They're going to be safe to their patients. They're going to, be able to effectively do the job
Yeah.
that this is, right? So that's what standard is. And to my mind, standard also means everybody achieves the same thing.
The standard. Yeah.
Right. So I guess let's look at the other side of this. If a standard is defined as a top level of practice, are there drawbacks to that?
Yeah, I think it is. When you're looking at it, our profession is not in isolation. Which we're not an island. We work in a bigger firm. So, as an academic lead, the whole university isn't based around physio. So I have to, and if I'm not achieving, because for resources, from whatever reason, then I fail. I might have reached competency, etc., but if I haven't signed off on reaching a standard, then effectively to my executive, my vice chancellor, etc., then effectively our programs fail. Whereas we might be a very good program, very competent, but because, as I said, when I was in Tasmania, we're an island state. We've got one university, a lot of rural areas outside. It's very low socioeconomic. It's our ability to resource to the same level that mainland universities, big university at the moment, isn't anywhere near that. So they're still bloody competent physios. They're still good quality, but they ain't going to win the Nobel Prize because we don't have the resources.
So were you just proposing there should be a Nobel Prize in physiotherapy? Because that would be kind of cool. That would be.
It should be high.
So this brings up a really fascinating intersection. And one of the things that I really appreciated being on the IFOM Standards Committee was this variable resources, right? Variable levels of practice that occur from one country to another. And, even in your introduction, that was something I was noting is that, you've done work in Australia, which has a really established infrastructure for physiotherapy, but then you've also done some things in other countries that have different levels of resource. So how do people accommodate that what's the intersection between resources and standards?
Yeah, I think there's also, I think there's a cultural thing as well. When working in Asia, that there's a lot more need to be definitive. How many hours do we need to do in clinical education? And interesting, physio in Australia has dropped the number of hours required for clinical education for accreditation, but it's still there in occupational therapy and speech pathology. And so we've gone in our standards to more open statements, more generic statements, and culturally, a lot of the Asian universities really struggle with that because culturally they want to know how many hours do I need to do, what do I need to cover, what content do I need, etc. And our standards don't really have that in them. They're more motherhood statements, but they're more broader and less able to define, and so they're open to interpretation, which makes it very difficult when you're running a program and you're trying to achieve standards if the standard's not black and white.
Right.
So,
right. I would say, I guess the opposite side is that there's flexibility to accommodate difference in resources.
To a degree, there still needs to be a base standard. And that's where I think it goes from the base standard to above. The base standard has to be, I think personally, this is, so many hours of this, so many hours of that, as the minimum. Then I think a good program would allow recognition of those who go above the standard, but there should still, I think, there still needs to be kind of that basic standard that they can sign off on.
Right. Achieve the minimum, and now here's your flexibility to go do other things. Yeah. I also think if we're talking about what are some challenges of setting, considering standards as a top definition, right? Here's a set of standards. This is the top. This is optimal. Or if we try to make standards that define excellence, I think, kind of ironically, what you're doing there is inhibiting excellence. Because excellence comes from, and this is core to what I'm doing with this podcast, PT Outcast, right? This comes from people who are stretching the box. This, excellence comes from people who are redefining practice, who are introducing new things into practice. And if you've defined what you consider excellent, well, then you're sort of by nature risking limiting that innovation.
Yeah, that's a good perspective. That's a good way of looking at it, because it is um, a risk associated with setting really rigid standards. But it's just that, I found, particularly from my recent accreditation, that, and fortunately I was at a workshop afterwards where we were redeveloping it, so I was invited to this workshop. And it was between the time that I'd submitted my paperwork to they were doing the site visits. We have a process where they come out and visit, and I was still unsure of whether I had achieved the standards. And I'm saying that shouldn't. I should know from the
Yeah.
documentation, have I reached it, yes or no? I shouldn't have to spend 2 weeks stressed out to my eyeballs, not knowing, have I reached the standard? Because they're worded in such a way that it wasn't clear. I don't believe it was very clear. It's open to interpretation. It should be that I know this is the requirement, and I've done that. I'm still going to aim high. I think all academic leads, all videos do. They want to aim higher, but at least you should be able to go, my program's up to standard.
Yeah. I keep resonating on this thing that you mentioned a few minutes ago about it's not in our professional psyche to achieve the minimum.
Maybe I've just been lucky with who I've worked with, but I think when you see patients, you always try as much as you're always aiming high. You're always, and I think once you get a department, you might have one person who's aiming for the minimum, but I can tell you there'll be enough who'll pull them forward. I don't think you're going to get a department where everyone there'll always be that drive to be the, our students, be our patients, be it the community we work with. It's always in our essence to aim high, but you should be able to confidently say to the community around and the students who are looking at attending your university, making a choice at your university, that we are up to standard, and so with confidence.
Yeah. Well, that's exactly what I was thinking about. What you said is that, it's core to what you do to patients, right?
Yeah.
Like when you work with patients and you're not like, listen, I'm going to get you to be able to bend your knee 90 degrees. And that's the minimum. That's our standard. You can do most things there.
Yeah.
So we're good. We don't need any more flexion.
Yeah.
It's not what we do, right? It's like, let's see how much we can get.
Exactly.
Yeah. Let's see what we can do here.
Yeah. Exactly. Like I find it's weird, the argument that that's the minimum people will go to. I don't think I've ever worked in, seen or visited any university or worked in throughout Asia that people are just going, oh, what's the minimum I can do? They want to know, how do I compare? Am I doing okay? Foundational, if you like, and then I can leverage off that.
Yeah. So now let's come back to this. I promised earlier I stuck a pin in this idea of scope of practice or advanced practice and standards, right? So how do we accommodate standards for advanced scope of practice, right? So, I can think about this in the US. We have our educational standards for entry-level physical therapy.
Yep.
Well defined. Another set of standards we have is what does it take to, complete a fellowship or complete a residency. Those are different standards, right? And so those standards theoretically define a higher level of practice. So there's still a minimum though, right?
It could be. Yep. Yeah.
So it's a minimum standard for a different qualification.
The problem we have in Australia and the UK, I worked in London as an advanced scope practitioner many years ago, is that there still isn't really a well-defined process for advanced practice. The master's degrees or MSK, physio, etc., but there really isn't a postgraduate specific for advanced practice. So most hospitals have a competency process within the hospital for their advanced practitioners. Again, that's not standardised between hospitals. There's and I think part of it is our position descriptions as advanced scope practitioners hasn't been really well defined. Our scope hasn't really been well defined. We've gone ahead, and in the UK, the drive was very economic. In the NHS, they're going broke. Everyone turns up at the hospital because you can't get into a GP. You can buy 3 physios for the price of a doctor, so let's get physios in there. It was the accountants who got us in, which is great. But we've gone ahead without, I don't think, developing our standards to catch up with what we're doing, and definitely not in Australia. We have nothing here. Even the requirement for a master's degree is variable, depends on the hospital.
Yeah, interesting. When I was, I guess I'll kind of share a personal story here. When I was the director of the Kaiser Northern California program, which previously was the Kaiser Hayward program, and that program when it started was called a residency. And as they defined themselves and the profession defined things, it became the fellowship, right? And so it was a manual therapy fellowship. So they already had this like history in their I don't know, world experience of once being called a residency, once being called a fellowship. And so I got there, and one of the charges that was presented to me was to create an orthopedic residency. And so the faculty then had this question, which was, well, what's a residency compared to a fellowship? Right. And on one hand, it's easy to describe because there's a group, we call them ABTREE, the really long acronym, and they define what is a residency. And then there's this, at the time there was ABTREE standards and IFOMP standards, which were aligned, and that defined a fellowship that has since changed. And so now there's the ACOMPT is a different, accrediting body now that helps work with IFOMP to define the fellowship standards. But when you put them side by side, and the faculty were astute enough to recognize this, there's not a really good definition of what is a resident and at that outcome and what is a fellow and that outcome. Is it that the fellow knows 50 techniques where the resident knows 30? Is it, how do you define, oh, I'm much better at clinical reasoning because I'm a fellow? It's really hard to define these things. And so I think that's another challenge with like, how do you make these standards actually achievable or useful? Because the stuff that's in them sometimes is very esoteric.
Yeah. And the problem is we're having in Australia is with, I think particularly the specialisation process, I said before, they're not recognised by the government or neither insurers because I work hard with the insurers because they're asking, well, what's the difference? Are you getting better results? Do you have the evidence that seeing a specialist gets you better results, safer results, more efficient results than your bog standard physio? If not, why would we pay extra? Just because you went to university doesn't make you smarter. It doesn't mean you'll get better outcomes. It means you can write better articles. It doesn't mean you can necessarily. So I think as a profession, I've pushed for years, I think we need to show the evidence that we actually, as a practitioner or as a specialist physio, you actually get better results because then we'll get the reimbursement in Australia particularly and the recognition from the government. At the moment, we're pushing the position without setting the foundation.
Right. Yeah. So, and that's sort of, you rang the bell there, right? Like, is this advanced practice? Is this standard that we elevated? Oh, cool. I made bubbles in my video. That was pretty fun. If you elevate this practice, does it also elevate outcomes? And that's a really hard thing to observe.
Ironic in evidence-based practice that we promote, we still haven't got outcomes for our profession. We're not developing, we're not looking for the outcomes yet. We preach evidence-based practice and outcome focus and research evidence, but we were still are not showing, are not even going there as far as I can see. I haven't seen anything yet, that particularly in Australia, that's saying that if you see an advanced practitioner or if you see a clinical specialist, you get a better result.
Yeah, and I think there's a lot of things that go into that, but one of the things that comes up to my mind relative to this conversation is that standards have defined this, what you should know, and there's practice standards that, and evidence standards that define maybe how you should employ evidence, but nobody should be afraid of standards because within that, there is still a vast sea of flexibility for how you practice and what you do, right? And that's to our personal benefit as, humans that like to innovate and explore and tinker and use our imagination, but it's also to our deficit as a profession because with that amount of variability, sometimes it's really hard to understand what we're doing and what the outcomes are.
Yeah, but I mean, we do have right across from how much creativity. It's still, according to the World Physio, we're about movement. So I think it's provided in functional return to function, etc. the key focuses, etc. So I do think there is similarity across all. It's just at what point do you constrain people? I think that becomes quite difficult to determine, really.
Yeah. So, it, we're talking about scope of practice. You mentioned sort of there's this interplay with economics in the UK where, we suddenly had a need for physical therapists to play a different role, to serve as more of a primary care role. Understanding that in different countries, the role of physiotherapists is different. Is there ever like an idea where standards should be, like entry level standards should be globalized to one set for everybody?
It would be good, but I think it's a struggle. It's the problem with standards is they come very much from a rich Western perspective, well-resourced Western perspective, transferring that into a medical system where the physios are very subservient to the doctors. And I think, particularly through Asia, it's still a very medically driven model. I think it's great. I think they should. That's why we need that minimum standard to help them, give them leverage if they can show that it's an international requirement, etc., to get resource to reach that standard and get the recognition they need as a profession. But it's still a very medical-driven model, a lot more than it is in Australia, and I know in the UK. I don't know what the States is like, but
Yeah, and I guess that's something to keep in mind too, as for people who are involved with the development of standards or the revision of standards, is that there's an economic side to this, right? Like when you set a standard, you are also setting a cost.
Yeah, and it has to be. There has to be value for money in it.
Right. What's the outcome from that?
Particularly from a university perspective, because our administrators, for us to get accredited, there has to be a reason for it. Now, in the undergraduate program, it's pretty clear. Without that, we can't exist. But I pay for it. Once you start getting outside of that, and it's not about an existentialist argument, but it's actually, it'd be good if we had this because we get recognition. Actually, with the belt tightening, it's harder to justify that expense to the hospital administrator or to the university administrator. Sorry.
Right.
And it gets expensive.
Yeah. So I guess let's bring this like back around. I think you live in academia, I live in academia. We've directed some programs, and for us, it makes a lot of sense to talk about standards. If I'm a clinician at the corner in a hospital, wherever I'm practicing, or maybe I'm online practicing, it doesn't matter. Why do I need to know about standards?
I think as an employer, I think two levels. A is, again, knowing that my practice is up to standard. We do tend to work as what I call the bedbound whitecoats in isolation, and I think there needs to be something which allows us to be able to say as a profession, all clinics wherever they are have achieved a standard, and then they can go above that. But also when you're employing, I mean, if you know they've gone through a program that's been recognised, they've reached that standard, then at least the quality have some confidence in the quality of what comes through. Provide those standards are competency based.
Yeah, here's a fun question for you. Can you think of a standard now in the profession that wasn't a standard when you learned how to become a physio?
I'm so old. I predate evidence-based practice. So the focus on research evidence has changed. It's a complete new paradigm, really, which is great. But I think a significant shift in the education standard. So. And it's interesting. We talk now. It's interesting with the Australian where they're bringing patient-centered care in as part of the standards, but we've always had that as a profession. That was, I trained under Jeff Maitland. That was the central core to his whole approach, was patient-centered care. It was the semi-permeable wall. We treated the patient's history, signs, and symptoms. The science was interesting and informed, but the patient was central. And it's taken 50 years now for it to come back into our standards. But the profession's always done it. But evidence-based practice is probably, I think, the biggest one.
Yeah, that's really interesting. I think I'm not as old as you, but I also predate evidence-based practice. Or let's say I was being hatched as a physical therapist as that term was being hatched. So nowhere in my curriculum did it ever say evidence-based practice, right? So yeah, the other one I think of for me would be like information about like social determinants of health. Right. That's a standard now in almost all education programs, but that was not a standard, back in when I was learning PT. Like no one would have ever said those words together, and no one ever told me that different groups of people might have different healthcare needs and different things to consider about what you know.
Yeah, biopsychosocial approach is also very biomedical through. So, but yeah, it's the other big change in the standards.
Yeah, so that's I think something to get back to the original question. Why do individual practitioners need to know about standards? Well, I think that's the way that you stay with the profession, right? And that's why we have continuing education requirements. But more than that, to kind of go to our psyche idea, this is the thing that helps guide you as you want to continue developing your mind about how to best serve your patients. It's this development of these educational standards. It's the what do I need to know to keep pace with the scope of practice that's happening. Yeah. So, I guess, we talked a lot about standards. What's the thing? What's the takeaway here? Like, what do we want people to know in general, big picture about educational standards?
I think for me, we need to be very clear when setting the standards. Is it the minimum standards, which means that we are getting consistency across all programs, or is it the zenith, where this is the peak that you should aim for? And that needs to be really clear, almost at the opening paragraph, I think, of the standards documentation, so that everyone is on the same page. Because I said my experience with our undergrad thing here is it's not clear. And so it's open to interpretation, which then becomes difficult as an administrator, as a program lead, to argue within a university environment. But I think we need to be clear what it is. I personally think it should be the minimum standard, but whatever, as long as it's defined, it's very clear.
Right. Yeah, and I guess my takeaway might be, you never know when your job is going to turn in a way that makes you have to know a lot more about standards than you ever thought that you might have to, right? So everyone who has a license as a physio is at risk to becoming a standard survivor versus maybe an expert. But yeah.
But then surviving's the thing, because when you look, this is what it's done to me. I'm only 21, and just having going through standards has worn me out. So.
Oh, that's great. All right, so I appreciate this conversation a lot. It's really stimulating to my mind. I guess I like to leave with like, what's going on in your life? Like, what are you working on next? What's your research plan? Like, what's happening with you?
So at the moment, I've actually got some a PhD student looking at advanced practice. We're looking at developing the competencies for it, so based on position descriptions, and because there's nothing developed in this area in Australia anyway. So we've got a PhD student working in that area. But at this stage, assistive technology is doing some work in that area. So a few bits and pieces research.
Yeah, great. Yeah, well, good. Let's wrap up this episode. I still have a lot more to think about, so we might have you back on and talk about standards. I don't know, maybe people will listen to the standards episode and get scared off and be like, this podcast is weird, but hopefully they won't. And I think you're entertaining. So really, thanks for coming on the show. PT Outcast is really proud to have you. So and it's really good personally to see you and spend some time.
Likewise. Thanks for the opportunity, mate. Look after yourself.
Yeah.
Cheers.
All right, great. Have a great day. And thanks again, everybody, for listening to PT Outcast. Cheers.